Osteoarthritis is the most prevalent musculoskeletal disorder, especially impacting adults over 60. Could you explain how osteoarthritis of the knee specifically affects physical function and daily life?
Certainly. Knee osteoarthritis leads to cartilage breakdown, making movements like standing, walking, or climbing stairs painful and difficult. In fact, studies estimate that 30–50% of older adults are affected, making it a leading cause of disability and reduced independence in this age group.
That's a staggering proportion. Since quadriceps weakness is often cited as a key factor, how does muscle strength relate to joint health in these patients?
Great question. Strong quadriceps stabilize the knee, reducing joint stress and pain. When these muscles weaken, the knee becomes less supported, which accelerates cartilage degeneration. Maintaining or improving muscle strength is crucial for minimizing pain and preserving mobility.
Given these challenges, many therapies exist. Let's transition to a newer approach gaining traction: blood flow restriction training. What exactly is it, and how does it differ from conventional resistance training?
Blood flow restriction training, or BFR, involves using a pneumatic cuff or elastic band to partially restrict blood flow to a limb during exercise. Unlike traditional resistance training that requires heavy loads soften 60% or more of one's max BFR uses light loads, around 10–30%, yet still stimulates muscle growth and strength.
That's fascinating. Can you simplify how restricting blood flow with lower weights can produce similar or even greater muscle gains compared to high-intensity training?
Think of it like exercising in a low-oxygen environment. The partial restriction increases metabolite buildup, like lactate, which signals the body to release growth hormones and activate muscle fibers more intensely, even with lighter weights. This metabolic stress mimics the effects of heavier lifting.
Are there safety concerns, especially for older adults or those with cardiovascular issues? And how does BFR compare in terms of risk profile to standard resistance exercises?
Current data, including systematic reviews, show BFR is generally safe when supervised and protocols are followed. No major complications were reported in the reviewed studies. The lower load reduces joint stress, making it particularly suitable for those who can't tolerate heavy lifting, though careful screening is essential.
Let's delve into the evidence. Systematic reviews have evaluated BFR's effectiveness for knee osteoarthritis. What do the latest randomized controlled trials reveal about its impact on muscle strength, pain, and physical function?
In a recent review, 4 high-quality RCTs involving participants aged 50–70 found that BFR training led to significant improvements in quadriceps, strength, and physical function. For example, most studies reported positive changes on measures like the 30-second chair stand test and decreased pain scores after 6–12 weeks of supervised BFR.
Were these benefits unique to BFR, or did they match what's observed with traditional high-intensity resistance training?
Interestingly, while BFR matched traditional training in improving strength and function, it didn't consistently outperform it regarding pain reduction or disability. One study noted greater short-term pain relief with BFR, but this advantage faded by 6 months. So, BFR is a solid alternative, especially for those unable to perform heavy lifting.
That's a key nuance. As we move forward, what gaps remain in the research, and how should clinicians interpret these results for real-world patient care?
While current protocols like 1–4 sessions per week, 1-hour durations, and moderate cuff pressures are effective, we still lack consensus on optimal exercise dosage and cuff settings. More research is needed to refine these variables and ensure long-term safety, especially for vulnerable patients.
Do you envision BFR becoming a mainstream therapy for knee osteoarthritis, or will it remain a niche intervention? What real-world barriers might limit its widespread adoption?
With mounting evidence and growing clinician awareness, BFR could become a standard adjunct for patients who can't tolerate traditional resistance training. However, barriers include the need for specialized equipment, training for safe application, and patient education. Insurance coverage may also play a role.
To sum up, it sounds like BFR offers a promising, evidence-based option for improving muscle strength and function with minimal joint stress. As research evolves, we may see it integrated more fully into physical therapy protocols for osteoarthritis and other musculoskeletal conditions.